Hi, I am Dr. Reynaldo Ong-Joson, Director of ROJoson PEP TALK. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP TALK. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Goiter, Part 3. This is part of the health disorder course. Empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of goiter, part 3. In part 1, I've taken up these topics. What is a goiter? What are the common types of goiter? What are the causes of goiter? How common are the goiters? In part 2, I've taken up clinical diagnosis of goiter and paraclinical diagnostic procedures for goiter. We're now in part 3. The contents will be treatment for goiters, health restoration and maintenance after treatment for goiters. Definition of terms in the title and the limitation of coverage of my talk. Fundamentals to mean the simplest and essential facts and theories which can serve as a basis or foundation and support for advanced and future information. Generalities to mean general statements of information, not covering specifics and details. Medical management to mean diagnosis and treatment usually done by physicians. Let's start with treatment for goiter. Formulation of the treatment plan starts with a pre-treatment diagnosis. There must be a pre-treatment diagnosis that is as specific as possible to serve as the basis for the plan. The pre-treatment diagnosis must have the name of the disease causing the goiter or the name of the thyroid disease and the extent of the disease. For example, the stage of a thyroid cancer. After formulating the pre-treatment diagnosis, including determining the extent of the disease and other factors with effect on treatment, first thing to do before considering and comparing the options of treatment methods or modalities is to spell out the specific objective or goal of the treatment. For cancers, whether curative or palliative. For non-cancers, whether curative or just control. After the physician has decided on the goal of the treatment, he gives or lists the various options of treatment and then gives data on the BRCA, which stands for benefit, risk, cost, availability. With the data given, the patient is asked what he or she prefers. Example of BRCA comparative analysis of treatment procedures. On the first column is listed or are the options 1, 2, and 3. And then on the second column, benefit in terms of goal of treatment. Example, greatest survival rate for option 1, least survival rate for option 3, and option 2 in between option 1 and 3. Let's say that the risks are all acceptable. The cost is 5,000 for option 1, 6,000 for option 2, and 3,000 for option 3. Just suppose that all the options of treatment are available. So which one is the most cost-effective treatment? The answer is option 1 because it has the greatest survival and reasonable cost at 5,000 compared to the option 2. Another example of BRCA analysis, option 1, lowest recurrence rate, option 3, highest recurrence rate, option 2, in between. Okay. Risk, assuming that they're all acceptable. and then costs, showing the differential costs, and then assuming that they are all available. Again, which one will one choose? The best option here would be option 1, because it has the lowest recurrence rate and the price and the cost is reasonable at 5,000 compared to the others. Another example of BRCA, most effective for option 1, least effective for option 3. Okay, at the risk, assuming that the risks are all acceptable for the 3 options, and then the cost is 2,000 for option 1, 3,000 for option 2, and 4,000 for option 3. And assuming that all are available, then the most reasonable option to choose will be option 1. It's the most effective, and it has the least cost. The usual goals of thyroid cancer treatment includes eradicating known tumors and cancers entirely, preventing the recurrence or spread of the primary cancer. This is the so-called curative goal. And then relieving symptoms if all reasonable curative approaches has been exhausted. So this falls under the palliative goal. At the time of the treatment, a patient may present with a cancer stage in which the goal is at best palliative only. That means relieving symptoms. These are usually the patients with advanced cancers. For patients presenting with early stage cancer, the goal is curative, that is, eradicating the tumors, cancers entirely, and preventing the recurrence or spread of the primary cancer. Thus, the objective of treatment is primarily dependent on the stage or extent of the cancer at the time of treatment. There are 4 common types or usual types of thyroid cancers: papillary, follicular, medullary, and anaplastic. For curative goal, the primary treatment modality is operation. This may be followed by radioactive iodine therapy, and then this may be followed by medical suppressive therapy using levothyroxine. For palliative goal, the usual treatment will be chemotherapy and radiation therapy. The usual operations being done for thyroid cancers are thyroidectomy, either subtotal or total, and neck dissection. There are different kinds. For the non-cancer goiters, goiters with functional disorders, there are 2, hyperthyroidism and hypothyroidism. For goiters with non-functional disorders and benign conditions, the most common is colloid adenomatous goiters. The goal of treatment for the non-cancer goiters will be curative versus control. Some don't recur after treatment, some recur. Only time will tell. There's no guarantee for cure even for the non-cancer goiters. They may need lifetime maintenance medications. For hypothyroidism, medical therapy is the treatment of choice, no operation, as this will only aggravate the hypothyroidism. And the treatment is usually replacement therapy with thyroid hormones, usually levothyroxine, and usually lifetime. For hyperthyroidism, there are 3 options for goiters that are small to moderate in size: medical therapy with anti-thyroid drugs, operative therapy, and radioactive iodine therapy. For those with huge size goiters, operative therapy is recommended. For colloid adenomatous goiters, there are 4 categories. You have the diffuse colloid adenomatous goiter, colloid cyst, solitary colloid adenomatous goiter or nodule, multiple colloid adenomatous goiter. The options for colloid adenomatous goiter in terms of treatment: 1, could be monitored without medicine. It could be treated with medicine, specifically levothyroxine, and then an operation is also an option. An operation is recommended for huge size goiters. Small to moderate ones, no operation, just monitor without meds or with meds. So these are the two options. Surveillance or monitoring is needed, usually lifetime, after treatment for the non-cancer goiters. Because, as mentioned, some can recur, and there's no guarantee for cure. Post-treatment health restoration and maintenance. After treatment for any type of goiter, whether non-cancer goiters or cancer goiters particularly, there must be surveillance or follow-up or checkup, usually lifetime, no recurrence, for recurrence. Okay. The purpose for the monitoring will be early detection for recurrence that may occur, and then after that, institute early treatment, and with such an approach, it will have a better outcome. Patients may be taking maintenance meds for the control of disease, and it may be lifetime. Patients are advised to have a healthy lifestyle to promote health restoration and maintenance after treatment. Except for anaplastic carcinoma, fortunately, these are rare, and for advanced cancers, the rest can still have a long life after treatment. Summary and takeaway. I have discussed the following in part 3, treatment for goiters, health restoration and maintenance. Takeaway in relation to patient empowerment. Be always in touch with reliable medical information on fundamentals and generalities in medical management of goiter. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment. Kaalaman, kakayanan, karapatan, at kapangyarihan to gain greater control over decisions in the medical management of goiter. With that, I end my PEP talk, Fundamentals and Generalities in Medical Management of Goiter, Part 3. I hope I have empowered you to have an understanding of the fundamentals and generalities in the medical management of goiter, Part 3. Thank you and good day, and mabuhay kayong lahat.